We had a scheduling issue today with those who were supposed to be with us, who were called, had some patient-facing activity that they had to prioritise, which is absolutely right and appropriate. That we will bring them back again another time. So, noting that we do have a very heavy board agenda today with some critically important items on it, including the trust strategy, the clinical strategy, and we do now have a little bit of additional time to give to that, which I hope everybody will find to be of benefit. I have not been notified of any apologies for absence, but can I just check? No. In terms of any declarations of interest, are new ones being discovered by anybody? Before I go to the minutes of the last meeting, I would want to formally welcome to us. We've got here in the room, we've got Robert Toole, who is now our permanent Chief Finance Officer. And Robert, thank you for joining us. And we would of course want to thank Kish Sindhu, who was with us for several months as our interim. So with our thanks to Kish, it's great to welcome Robert. And in the same spirit of welcoming, last time we met in public, we were saying farewell to Brian McCarthy, who was our NED responsible for all matters finance and audit and risk. And in Brian's stead, we've got Mark Balan. Mark, you are very welcome to the board of the CPFT. You've been with us for a couple of months. It's lovely to have you here with us at public. Let me go then to the minutes of the last meeting held on the 24th of September, which was not quite as cold a day as today is proving to be. And we'll go through in the first instance for accuracy. So on page 1, page 2, page 3, 4, 5, 6, 7, 8, 9, 10, 11. Oh, sorry, Steve. Sorry.
Just one. 0925 19C. The consultants who are working on the Children's Hospital joint endeavour are called Stresses, not Structures.
Yes, and I think Kathy had already notified Martin about.
I've been advised of a very small number of typographical errors, which I'll pick in the master copy.
Yeah, so where people have notified, these are being updated. Thank you, though, Steve. Page 12. Page 13. Okay, so with the small number of updates that Martin's been advised of already, we are agreeing that that's a true and accurate record of the last meeting. So then I want to go to the action log, and there are 3 items outstanding here. I will go to the one in the middle first, which is to invite a clinician involved in the hospital project, the Children's Hospital project, to come to the board to talk about clinical assurance and integrated care. Where are we with this? I'm looking at Kathy and Martin.
Well, there's 2 elements. We need to find a space in the board calendar, so that there's also just we're confirming the availability of that individual. So
We're very happy to come.
We'll prioritise it
Whenever the slot is available. All right. Well, I think given certain timing issues around the Children's Hospital, the sooner that can come, better, really, which would be good. So then I'm going to other items where updates were promised to the board. So, Holly, both of these sit with you.
Yes, I'm here.
So, Holly, let's start with the out of area placements plan. Can we have an update on that, please?
Yes, indeed you can. So a plan was shared through Business and Performance Committee. It's a plan that actually is looking at overall patient flow, because if we improve our patient flow, we will reduce our out of area placements. There is project support aligned to the Directorate, looking at the implementation of a new patient flow model, which is called the NAV model. So it's thinking about whether admissions are appropriate, are necessary, appropriate and value-based. That had a soft launch in August and went live in October. It involves a slightly different way of looking at flow, so introducing red to green, which is a process of identifying what is the next positive thing that needs to happen in a patient's journey to get them closer to being discharged to their normal place of residence. We've also linked in with local authority to look at doing some multi-agency discharge events, and we've got those scheduled throughout the rest of this financial year, and looking at a new way of the multidisciplinary team working, and that's being led by one of our consultant psychiatrists who's based in Peterborough, but it is covering both the Fulbourn and Peterborough sites. So that project is progressing as planned, and we are seeing small reductions in our length of stay currently, but our out of area placement position remains positive in terms of reducing.
Any questions, or Steve?
Just a brief one, Chair. Thank you. And thank you, Holly, for updating on that. The project to look at length of stays is really quite innovative, and I think it's something that I would very much like the board to see. And I think it would be probably looking at the Chair of our Quality and Safety Committee, something that we would take through Q&S to start with, but definitely, Chair, if the slot allows for the board to see what work has gone on, led clinically, to look at our length of stays. We know that the length of stay in the flow is directly proportionate to the quality of the care that we give. So I think it would be something I'd most definitely like to bring back here.
Like,
Yes, so two things. One is that the quality, the integrated report is now starting to report on those things such as length of stay, so we can start to monitor that. But we talk about inappropriate and appropriate out of area treatments, and I think we're still in the position where so-called appropriate out of area treatments, and we can argue about the language, is driven by the lack of female rehabilitation and intensive care.
So it's female PQ and rehabilitation for both male and female.
Right.
Inpatient rehabilitation.
So I wouldn't want us to lose that so it's not simply, I think, an issue of flow with our own patients, but it's also, and for me, I think that the argument for repatriating those patients is unassailable in terms of financial quality and equity terms.
no, it's a point well made, and a point that's come to this board very often. I think given that we don't appear to have system solutions to our absence of female psychiatric intensive care in particular, I think it does behove us to look at the capacity we've got within the trust, where we're not fully utilising all bed stock, and to think about what we can do to repurpose and rather than wait for a system to support us, become the people who actively seek to sort this out. It is a stain, and has been a stain on Cambridgeshire and Peterborough. This hasn't been funded or prioritised. And I know that we've been asking for it, but I think asking has got us nowhere, and now we've got to find the solutions ourselves.
So we are looking with our estates colleagues at what opportunities we might have. We know that we could do some remodelling, and obviously as the project progresses, that is part of our project plan, because we hope to get to a place where we will have some additional psychiatric capacity that we could then look at to safely repurpose. So that is work that is ongoing.
I think the board is inviting pace on that one. Mark?
Yeah, I suppose the question, what's our timing for this? So when do we anticipate that? Either we'll have a concrete view of this is what we can do, or this is what will take for us to do it. So either the executive or the board can take a decision of, yes, we want it done, now let's proceed.
So I think in terms of the project plan overall for the out of area placements, that takes us currently to April 2026. But that doesn't mean that we can't do the work in between now and April to look at if we achieve the reduced length of stay that we're aiming to, what opportunity does that give us? And then understanding with estates colleagues what estates work would be required to repurpose some of our capacity.
And not to delay too much further, but I think it's probably true to say, when I talk to staff, that one of the greatest reasons for delayed discharge is absence of appropriate housing for people to go to. Now we have talked here previously at the board about how some trusts doing not dissimilar work to us actually invest in having their own housing officer to be the link person. Have we thought about making some progress on that?
So we do have a housing officer, but we've also improved our relationships with both local authorities in terms of inviting social work colleagues into our new MDT as part of our new patient flow model. We have seen a small reduction in our clinically ready for discharge. But in fairness to our local authority colleagues, there isn't the homes out there in terms of that supported living. So we are looking at what else could we do, what else could we offer to enable those individuals to go to their place of residence, or what alternatives are there to supported living.
I think there would be an appetite to actually hear from the housing person at board level, so maybe we could have that at a private session, Holly. It would be good. Kathy.
Yeah, I was just going to mention that we've just had approval to support the Citizens Advice Bureau project. That's a pilot and it's funded on innovation money, so it's non-recurrent, but nonetheless it will give us the opportunity to bring 2 people from Citizens Advice Bureau, one north, one south, into the trust to support patients on the wards and in the community. So I think it'll be interesting to sort of align that with NOV and see whether or not those things forward.
Okay. Well, Citizens Advice do great work, so it'd be great to have them with us. Any more on that one? You look boys, Mike.
Well, only just to, for me, it'd be useful to understand the delays to discharge, both for the cohort of mental health patients and also mainly the elderly and rehab patients as well. That sort of granularity, I think, will be helpful because they are a different clinical group or groups, but both are important.
Yes, I can bring that through quality and safety.
Excellent point. Thank you, Mike. So then, Holly, we're still with you. This is another issue of equity that is a bit of a theme for the day. ECT treatment in the south of the county.
Yes, so I think the board will recall that we took this particular issue to the System Quality and Safety Board, again trying to get some traction in terms of this is a life-saving treatment, and as colleagues know, we can't deliver that in the south. I have to say, and Rachel was present, I think we were slightly disappointed at the reception that we got through the System Quality and Safety. One of our private provider colleagues, Spire Healthcare, offered to meet with us and to look again at whether they could support providing ECT in their base, which is in Histon. We had a very positive meeting with them. They were actually very quite excited about the potential. However, they have come back to us last week to say that the Spire's national team have said that this isn't a group of patients or a treatment that they are looking to branch out into. So I have since written to the ICB on the back of going to the System Quality and Safety meeting to say that actually we're really disappointed in the lack of progress, and that actually we want them to think differently about how we are approaching risk. This is about the availability of theatre capacity to provide ECT, and we know that in our South acute provider, they are providing routine surgery and we are not able to provide a life-saving treatment. So we've been invited back to the system quality and safety meeting to have a broader risk-based discussion. But in the meantime, we've had an executive discussion, and I've met with Alison Manton from our estates team to look again at whether we can find any solutions on our Fulbourn site.
We have talked about this so many times. I really writes large that the NHS plan talks a lot about addressing health inequality. This is a real lived issue of health inequality that has prevailed for far too long, and I think we will continue to do absolutely everything that we can do, and that does include talking about the fact that we are part of a system and we've got a collective duty to do our best by those who are most unwell. And if we were talking about restricting access to a life-saving cancer treatment, I'm absolutely certain that that would be on the front page of many newspapers. This should be treated with equal seriousness, and it is more than regrettable that it is not. All right, Holly, we will want to keep coming back to this, and thank you to you and Rachel for the work that you're doing on it. I think we all appreciate it. Thank you. Haven't been notified of any other business, but has anything occurred? No. Okay. All right. Well, let me go to my report, which is there for everybody to have read. But there's a couple of things I would want to draw out. The first is it would be completely wrong, I think, not to talk about the dreadful events of the knife attack that occurred between Peterborough and Huntingdon, and the events around that, of course, which now appear to involve London, other bits of railway, Peterborough itself as a place, and then the railway attack itself, which culminated in the arrest of an individual. For all of us probably who are in this meeting and those who are joining online, this is the place we call home. It's a place where a traumatic event occurred, and I think it's right to draw out the crisis response, which was exemplary, as I gather, in terms of the way in which all the blue light services, all the health partners came together to deal with what was an incident of, national significance in terms of the reach that it had. And I think that's probably because, a little like the bombings of 7/7, we take our interactions with things like public transport as being something that we do as part of our normal lives. And when a threat presents itself in such a setting, it just undermines our confidence in the way that we go about our daily lives. And I certainly know, in terms of putting my daughter on said railway line the very day after that incident, I had a thought about that I've never had before around, is it safe for this to happen? So I think what I'm saying is, it is traumatic and it is horrible, and that trauma lives with people for often the entirety of their lives. So I thought so with those who were most exposed to it, those who had to deal with the aftermath of it. And thanks to those CPFT staff who've leaned in to support with psychological therapies and support in real time, because that's an important part of helping people to deal with immediate trauma, but also in recovering from it. And also to some of our staff who, through relatives and direct engagement of actually living in proximity to the incident, were also impacted. I'm sure that this is something that we will be hearing about for a very long time, but we must also always remember, at the heart of it, there are individuals and there is lasting trauma, and part of the work we do is in supporting people to deal with that trauma, and that's what we will continue to do. I also want to talk about, in terms of lasting trauma, pay tribute to the mother and stepfather of Alice Figueroa, a young woman who actually died in 2015, but it's taken 10 years of hard work and campaigning by Alice's family to bring to the attention of the courts the failings that occurred in terms of keeping her safe. And I think a key learning was that of not proactively or sufficiently listening to input from families and those who loved Alice, who felt that there was more that could have been done to support her to get better. We have had many instances where we have had to think about the learning that we take from incidents. There is certainly plenty of learning that can be taken from Alice's death, and I know has been done. But I think what it does is remind us that the duty of care that we have for everybody that we look after is profound. And part of that duty is to learn from each and every incident. And if the learning is to learn faster and to listen more, then it is incumbent on us as the NHS to do that and to respond to it. And as I say, to pay tribute to Alice's mother and stepfather in particular for the hard work, forensic work that they had to do to bring light to bear on incidents that had a tragic outcome. So I think that is probably enough from me, other than to do what I seem to be doing every year at this period, which is to please encourage people to get vaccinated for anything that you are eligible to be vaccinated for or against. There is an awful lot of flu around. I know too many people who are unwell and have said they hadn't quite managed to get their vaccine because they've been too busy. So the onus not on it being offered, but on the busyness of life. Flu is not a trivial illness at all, and it does impact people differently and significantly. But it also, of course, impacts on the ability of services, public services we rely on, to be fully staffed and to be places of care and safety when there's a lot of it around. So I'm going to end with my public safety announcement, which is please, if you're eligible to be vaccinated, please do be vaccinated. So thank you so much on that. Steve, I'm going to go to you for the Chief Executive's report.
All right, thank you, Chair. Good morning, everybody. I'm just going to show the Chair I've had my flu jab badge, just to...
I wouldn't be sitting next to you.
Yeah, I think, and thank you, Eileen, for making those comments. I think myself and certainly the executive team would echo every single one of those comments that you, with a second set of thank yous for all of the agencies that were involved in both the incident at the time and also supporting the incident as that continues. So thoughts to those affected significantly. Thank you. I'm going to just skip through my report, Chair, with a couple of highlights, if I may. So I'll take the report as read, but if I can just dwell on a couple of the points that are contained within it. So 2.1, the medium-term planning guidance. Stephen will probably touch on this in his report when we start thinking about the trust strategy. I think it's safe to say that the planning guidance is quite fluid at the moment. There's a lot of asks on providers with a short period of turnaround to produce information to go back to the central team. Principally now, the 2-year planning guidance was released maybe a couple of days ago in terms of what it was that colleagues were expected to do. That includes 2-year performance figures, 2-year operational figures, 2-year finance plans, 2-year workforce plans, and 2-year strategic plans, amongst a range of other things. So the team will be working with our directorate and operational colleagues to try and turn that around. There are second sets of returns that are due in February. They are 3-year plans, and this is all a lead up to the start of next year's planning cycle, where we start talking about principally the next 5 years of the NHS 10-year plan. There are some things that fall out of that guidance that are very pertinent and relevant to us. So Mike, you made reference, thank you, to the longitudinal view of out of county and out of area placements. And there is a really direct, it's very good to see a direct statement in the NHS planning that says that should be as close to zero as possible. The narrative that we use, the national narrative, appropriate, inappropriate, I don't like that. I don't think anybody likes that. I think, if I'm being really candid, it should be the difference between commissioned and non-commissioned. So I think there is a piece of work at the moment where we as a provider with the right opportunities, can talk to our commissioners about trying to expand those services where possible, to try and support people from going out of county as best we can. I think as we move into that, obviously the consultation process for architectural changes across the NHS are now in full play, and you'll see those both in our ICB colleagues, Department of Health and Social Care, NHSE colleagues, as well as some providers that are going through those changes. So we have to remember that this affects thousands of members of staff, and this is very unsettling for them at any time in the year. Prior to Christmas, it must be very difficult. But also we have to remember that in the midst of all of this uncertainty, we still have to link in with these organisations and officers to make sure that the, pardon the phrase, but the day job continues. And that's really difficult at the moment because people are moving in and out of those spaces regularly. So again, thoughts to those colleagues as we go through that. If I can just touch on 2.2, colleagues will recall last week concluded the resident doctors strike, at least the latest resident doctors strike as it stands. And I want to express thank you to certainly the Chief Medical Officer and her team, the EPR team, and everyone else that was involved in managing the rotas, managing the support to our workforce, and also, stepping in to support any shifts that we needed to make sure that we maintain safe services. The lessons learned from the previous resident doctor strike were all deployed well, and it was nice to see that we've been able to do that in a streamlined way. In fact, I recognise that our performance didn't deteriorate or dip during that period. So a massive thank you to the workforce for being able to continue to keep the show on the road. That is a very difficult time. That leads into our performance conversation. So our performance conversation at the moment is revolving around a couple of issues. One is the National Oversight Framework, NOF, as it's routinely called. You'll be fully aware, and looking at Steve through the Business and Performance Committee and other colleagues around the board table, of our integrated performance report that's now been aligned and reabsorbing the NOF ratings, which is really important that we then maintain a clear view on our performance compared to the national scrutiny that all providers are under, and work is ongoing against some of the indicators that sit across that, where we believe that we need to put a little bit more energy. I'm delighted to say that I've seen significant progress in those areas, and just looking at the Chief Operating Officer, I would ask her to nod in that direction, that there's a lot of work going on. There's still work to do, and if there wasn't, then we wouldn't be looking hard enough. So I think we'll bring back the next NOF rating when that's released, and we're expecting that towards the latter part of this month or December. I think the quarterly reporting, is there a date for that yet?
No, we were hoping that it would be this week, but it's not looking as if it will be. So I think we would hope to have that before Christmas.
Great, thank you. And we'll appraise the board and our committees of that as that comes out. So we are expecting movement in those areas. I think I would like to put on record that the NOF is a useful tool for insight, but it's not the only tool for insight. And I'm delighted to tell the board that we've also embraced the model hospital data sets and the GIRF data sets as benchmarks across all of our services now. They're also starting to look across our well-led programme, our CQC well-led response, and some of the areas where we feel we need to improve. And that peer average and peer benchmarking information is really useful to make sure that we get a real sense as to where we are. And that goes into one stage further, which is being average and being part of average is fine, but still not good enough. So we need to make sure that we don't use that as a reliance to say it's kind of all right, we're in the pack, because that's not why we come to work. So it's just good to get that insight to see where we're outliers. I want to say thank you to Eileen for thanking Kish Sidhu, who worked with us for a couple of months. And Kish, if you listen to this recording, I think it is fair of us to say thank you for being a stalwart member of the team and also helping us through quite a difficult patch, which is then leading into a small drum roll and a big welcome to Robert, who sat on my right-hand side. It's needless to say, Robert's been with us 2 weeks, and so therefore has passed the induction stage and is now a veteran, Robert. So no excuses, I'm afraid, as we move into that. I'll pick the pace up, Chair. So under 2.6, 2.7 and 2.8, I just want to say that This year we did something different outside of our normal staff award process. We wanted to take a week to celebrate the workforce. We wanted the workforce to celebrate their peers, their colleagues, and to reach in and support each other over an entire week where we were able to say thank you to everybody for what they do. Staff awards are really important to recognise those teams that have excelled, but our Pride Awards do that beautifully. And I think this time we wanted to say to the entire several thousand of people that work for us that actually every one of them is valued, not just a small group of people. Feedback on that has landed very well, and Chris and the team are working through where we can improve on those next year as we work into this to see whether or not it worked. And so if any of you had any comments, please send them to Chris. And I think as this is an iterative process, we'd like to do this each year and do this better, because valuing our workforce is something that we want to make sure that we do on a regular basis. That value extends to those looking in on the organisation, with two of our teams winning Royal College of Psychiatry Awards, which is fantastic, one of which is a world first in terms of stepping into using research in an applied way to demonstrate digital virtual ward management of things like clozapine, which has attracted the attention of several agencies. And I'm delighted to tell you that Kathy and I will be meeting the Dean from the Royal College of Psychiatry, who wants to get involved in talking about how AI and data and digital and the use of new technology can support the Royal College in terms of its strategy, which is really nice for us to be involved in. And then I'll land on the Health Service Journal Awards, where we had two teams that didn't win, but were shortlisted. And we all know that if you're shortlisted, that's the real prize, because if you win, it's politics. I'm being no sour grapes there at all. But the reality of it is that we had two teams that were recognised nationally by the entire of the NHS, which was brilliant to see. And well done to those teams. We're very proud of you. I'll end on one final comment, Chair, which is Friday is the conclusion of our staff survey. So the national survey closes on Friday. We are roughly at half of our workforce at the moment, which is great. So nearly 50% of our workforce has completed this. And any of you that have a spare couple of moments that haven't done this yet, please do, because we recognise this is really important for the insights from you of how we want to improve as an organisation. And I'm delighted to say, looking at Stephen for a second, a lot of the feedback from the previous year has been acted on. And so it's really important that we listen, we hear, and then we do. And this survey is a good example of how we do that. Not the only one, but still a very good sample of that. And I'll happily end there, Chair.
All right, thanks so much, Steve. I wouldn't want anybody to leave with an impression that we think 50% is sufficient. We'd love to get to 100% completion. That seems tough in the NHS, but we should keep pushing for it, because everybody's voice absolutely does matter to us. We stay with you for the board assurance framework, Steve.
Thank you, Chair. I'll pick up the pace with this. So you'll notice that this is a revised format, and this has been streamlined with a summary sheet at the front to give you a good indication of the work that we promised to bring back to the board and back through our committees. Thank you to the chairs of the committees for working closely with our company secretary, Martin, to work through revisions to this and to keep this as a live document. But we will recall that board assurance framework is not the same as the operational risks, and therefore it's unusual to see rapid movement in board assurance because they're more strategic at that level. So I'm happy to pause there. Martin, is there anything that you'd like to raise? Thank you for the work you've done on this.
Just to point out, there'll be some further review and sort of refinement ahead of the next cycle, so they'll come through each of the committees.
Great, thank you. So I'm happy to take questions, Chair.
Steve.
Thank you, Chair. So really good to see the progress and the format reflecting the comments that we made at committee, and as Martin said, look forward to seeing it come back. Just a couple of questions that have just come out of some of the detail. We've spoken previously about population health needs assessments, and it's sort of listed there under the effective patient carers specifications that's been developed for it. A really important piece of work. I just wondered the timelines for that and how we're going to link it into underpinning, using the data from it to underpin our strategy work. And the second, it might be an interpretation of, or my reading of the capital resources risk with the target, and the current risk score is likelihood is of 1, when the risk is about whether the trust will have sufficient capital resources. It sort of gives the impression that we will, or we have sufficient capital resources. I'm not sure that's the case, but it might be just an interpretation of something to pick up. Happy to pick it up after the meeting. But, so there was just those two points.
Thank you. Happy to pick up on those. I think the first, excuse me, is on the board agenda today. We've got the conversation around the clinical strategy and the organisation strategy, and I'm delighted to say that both of those are informed by the population work that Catherine Faulkner and the public health team have completed. I'm also secondly delighted to inform the board that that's been shared with our local authorities, and so the health and wellbeing boards in terms of their key actions and the public health, the directors of public health in both of our local authorities are tuned into those strategies. There is more work to do on how we move that into place and neighbourhood as that starts to evolve, and that'll be brought through to the board as that starts to get more clarity. But the clinical strategy is most definitely informed by this, and I think this is something that we should be incredibly proud of, because it's unusual for an organisation to be able to commit to a clinical strategy, so we should celebrate that. But then having insights from those with lived experience and having insights from informed data from our population, that, if I dare say, Steve, isn't just a reflection of what we have today, but is more of a reflection of what is happening in terms of demographic, sociological changes and epidemiological changes in the population. It's incredibly important for the next 10 to 20 years. So I think that'll start to come out. And then finally, we want to make sure that that informs an evidence-based when we start working with commissioners over redesigning service specifications. Rather crudely, that's talking about rebasing demand profiles and looking at acuity in some of our services. The second point, I'll happily suggest that assurance, Steve, gets taken through B&P.
Yeah.
I know there is some slippage with regards to our capital programme at the moment, and Robert might want to comment on that.
I was just going to comment on the target scores for all of the three finance related. And I would suggest that they need reviewing, given the ongoing state of the NHS and finances, whether income, managing expenditure, and particularly capital. I think a target of those sort of numbers is very low and actually in reality unrealistic. But I think the key point is that we make sure we're doing all the actions to address where we can possibly to get that actual risk down from where we're at now into a more reasonable level. That's the key. I'm sorry, I did review this beforehand, but I didn't change the numbers. I did add some extra commentary, but I haven't done anything in terms of, frankly, because that's committee discussions.
Then, Robert, so
That's committee discussion.
we'll forgive that one. I'm going to go to Mike and then to Mark.
Forgive me, Chair. I think, Mark, you might want to talk.
No, that's fine. You can go
That's
first.
okay.
Could I ask, again, under patient care, there was a detail. We have heard before that the ICB are doing a piece of work looking at service specifications, which will affect patient care. And I don't know if now's the appropriate time to ask where that has got to, because it was a piece of work that was started in the summer. And has it reported, and how will we respond to that review of the service specification?
Lovely, thanks very much. I mean, so basically that piece of work, as you say, is continuing to track through. At the moment, the organisation called PPL has produced some draft reports. Those reports currently are with our operations and clinical teams. As I say, it's in sort of early draft. We're actually meeting with them at 5 o'clock today for a bit of an update on that, and obviously we'll start reporting through to B&P once we actually begin to see some of the output and some of the information associated with that.
Mark.
I'll tweet some things offline. I think it would be good to have what the colour codings mean on the document, so people then know, especially on the RAG status, because I assume green is on track, amber is at risk, and red is overdue. But then what is blue? And so I think having that kind of detail just allows people then to link it more through. Similar to Robert, I think looking at going from like a 20 score down to a yellow score by March with very limited mitigations, you think, is that really kind of realistic? So I think looking at some of those things again, and I think also where we have dates, again, if the dates are now passed, are they still realistic dates? So we need to make sure that we don't have like TBCs, we have actual dates. And if dates are now no longer realistic, we have to then come up with new dates. And then we show the old date, the new date, so then you can keep track of those items. But I'll separately out of the meeting, I'll come back with other points on the document. And the final thing was, how do we use this going forward? Because it's great having a risk a board assurance framework, but how do we use it in making decisions on things which we do, invest in, disinvest in, and the decisions which we make. So how we build it into that information going forward, because we need to show that we are focusing on the high risk items.
Come back, Steve.
Yeah, thank you. That's super helpful, Mark. Thank you. So the first bit, yes, please. The second bit, I think I'd like to throw in the mix. We need a conversation at maybe a board development session of how we reset our risk appetite. Because our risk appetite processes at the moment, given what Robert said, is the landscape's changing quite quickly. So I think the organisation's position with some of our strategic issues are crow's nest in terms of looking ahead. The risk appetite needs to be something that we look at with every decision that I think we make. So I think we'll bring that back to a future board. And Martin, if I can pick that up with you, because I know that was a piece of work that has been started. Thank you.
Could I just indulge myself one question on the VAT, Steve, if that's okay? And it's related to the working in partnerships to deliver section. And I just sort of wonder in that, where it's sort of got a moderate risk, whether we are reflecting adequately enough our relationships with our GP colleagues, who of course are absolutely core to the work we do, and the interface that we have with them and the support that we should and are providing to them is often critical. So I just wondered what your thoughts are on that and what more we should be expecting of ourselves to support our GP.
Yeah, and if I sort of make a quick start and then ask Kathy to comment, and likewise, Mike, I know that you're close to this conversation. I'm very grateful actually to GP and primary care colleagues for reviewing their interface with us. I think it's really important that we do that on a regular basis. I'm also very grateful for the fact that they've been able to capture that in quite a clear and articulate way. Some of that will be on perceptional interface, some of that will be on contractual or transactional interface in terms of how we relate to each other on a working basis. But irrespective of where it comes from, it's really important. I think that general practice GPs are core members of organisations like ourselves, and that relationship is something that perhaps hasn't been fostered to date as well as it could be, and something that I think we should definitely take on the chin as an organisation, that it is an area that we need to improve. We've reached out to our LMC colleagues and we want to have a conversation with them around what learning is there for us and how can we start to build those bridges, or at least cross those bridges collectively together, rather than as being quite a transactional relationship where I think it currently sits. There's learning on both sides of the fence, and speaking to senior officers in the LMC, I'm really delighted for the fact that they're open for this conversation. And I think their initial report that challenged us was one to start the discussion, which I'm really pleased about. And I think that's something that I would like to bring back to the board, particularly with the view of where are those areas where we could improve and do better for our local people, because that links into day-to-day relationships, but quite frankly, it also directly affects some of the people we care for. So, Kathy, can I ask you?
Before you do, can I just ask you to set out who the LMC are, Steve?
Sorry, the Local Medical Council.
Kathy.
Yeah, so agree with everything that Steve has said, and we've provisionally set up a meeting in December to include myself, Steve, Mike, and Nicola Deemer, who's our Associate Medical Director, who's also a GP. And myself and Nicola have presented a paper to execs last week outlining a proposal for a GP engagement strategy. And we bring that back to the next exec meeting following comments. And then we're hoping we might get that as part of our portfolio assurance board and make it into a proper project, because we have a range of potential interventions around communication, joint learning, etc. And I think it could be really very, very good. So we can report that. We're happy to do that.
And I think worth saying, when I talk to some teams, it seems like they've got absolutely brilliant relationships with
Yes.
the GP community, and so it's the consistency of the relationship, I think. Mike, and then Rudolph.
So I should say, for those who don't know, I have been a GP throughout my career, so I've experienced what life is like in general practice. So 2 points. One is the survey that our colleagues at the LMC have undertaken was only about our mental health services. And I think we want to broaden our conversation to include our community nurses, specialist nurses who work very closely with our. Secondly, we employ GPs to provide cover. So I know that we've got a GP who does health assessments for our very long stay patients, for instance, on the George Mackenzie ward. So there's a relationship there. And then the third is, again, this is my opinion, but I think it is important to distinguish between general practice and primary care. So general practice are the clinicians who work in practices who provide care to their patients, their registered list. Primary care is a much broader thing, which includes pharmacy, optometrists, and there's much you can do actually in the world of pharmacy, for instance, in supporting patients, medication reviews, so I wouldn't want to lose that broader, and it's sometimes quite lazily done. We talk about general practice and primary care as though they're synonymous, and they're not.
Yeah. Rudolph.
Thanks, Alex. District nursing is something that we provide as
We
well.
do,
isn't it?
yeah.
I mean, I'm just keen that in due course we also see that feedback on us, perhaps coming through quality and safety, because that external perspective on how we are to others is incredibly valuable to see.
Think about the theme of the NHS needs to get better and quicker at learning, is I think where we need to be. All right, thank you very much, Steve, for that. Any more questions on the board assurance framework before we move on? In which case then we'll move to the quality and safety section of the meeting. And Mike, we go to you for the quality, safety and patient experience committee report.
Thank you. So this assurance report refers to the Quality, Safety and Patient Experience Committee that met on the 22nd of October. Some of the topics we talked about have already been picked up in this meeting, notably the provision of ECT treatment in the south of the county and out of area placements, which whilst we see an improvement in that position, we've talked about the lack of female beds, for instance. Very pleased and excited to report that we read and discussed and approved the health equity strategy and the clinical strategy, which again are both on the agenda. So I don't know, Chair, whether we save that discussion.
I think we'll come back to
for
those later. Yeah.
later. Just 2 points though. One is the clinical strategy emphasises what I think is a simply said but profound issue where mental health and physical health are the same. And we've talked about that in regards to the Children's Hospital, but this I think broadens it to all our patients. Whilst we provide services in different institutions, from the patient's point of view, they're the same. And last, Dr. Price came. She chairs the newly formed clinical ethics group, and I think that informed the development of those strategies, but she's also going to report from a governance point of view to the Quality and Safety Committee on a regular basis, which I think is important for us to be aware of. Moving on, I guess you can ask questions about all of this, but the other point I want to draw out was that we had a presentation on the quality and equity impact assessments. These are an important component of how we're approaching our efficiencies and service changes in the organisation, and we're pleased to hear about that, both in terms of decisions about which cost improvement plans we were going to pursue or not, the risks and mitigations associated with those from a quality and equity point of view. And I think it's very important as well that we are open and transparent about the implications of our decisions with regard to performance and finance, because without that transparency, we lose, I think, the trust of our patients, staff and the public. So for those three reasons, I think these impact assessments are very
When it comes to the quality report, we may pick that up in the next paper, but there are a number of issues which we are discussing actively. So post-restrictive restrictive interventions and rapid tranquilization, blood pressure measurements after falls. There are a number of specific issues which we can draw out if you would like. We get a regular update on the well-led CQC action plan following the visit in February, but also all the other compliance visits through Jim Ledbetter's work. We received the quarterly safeguarding report. They are an extraordinary team who do very difficult work, dealing with very difficult circumstances, and the number of referrals are going up, 2,153 internal requests. So not only they've got a high volume of work, but they're dealing with high acuity as well. So we should recognise that, I think. We received the regular patient safety reports. We've got the IPC report, infection prevention and control. And I think it's worth pointing out under patient care experience, there's been an improvement in our friends and family scores. So we're pleased to see that, but there's obviously more to do. And lastly, there's been some interesting work which is feeding through the Quality and Safety Committee, bringing together how we approach quality improvement, co-production with patients and carers, and linking that with our quality priorities and the work that's been going on there. So thank you. That's perhaps enough for now.
It's always a very busy committee, Mike. Any questions or observations?
Just a very brief one. Thank you, Chair. Thank you, Mike. I think there's a lot in there, and we do rely on the committee to give us that level of assurance and oversight, which I'm incredibly grateful of. I think it would be remiss of me under the concept of what we call the quality impact assessments to not mention and say thank you to our medical advisory group, which is our group of consultant bodies that have also taken on initiatives to look at productivity and clinically lead on areas of improvement as well as a team. That is absolutely fantastic to hear. So that's led out by our Chief Medical Officer and the chair of the MAG, as we call it, but all of their work as well. Mike, it's really nice to see things that are clinically led, because I think leaning into this chapter in the NHS where austerity and performance don't match, we need to make sure that we understand the impact of what it is that we're doing. But I'm delighted to see a lot of that work start to develop with that level of clinical leadership. So thank you. And I guess we'll route those projects through into your committee when they start to get some significant traction.
Do you want to come back, Michael?
Yeah, no, so I agree. And I'm privileged to go to some of the MAG medical advisory group meetings. But the point I wanted to make, though, it's clinically led from a medical and a nursing and an AHP point of view, given the services that we provide. And I think that input is important. Yes.
Just before we move on, Kathy, is there anything you want to say about the ethics committee, which is
Yes,
just
so Marvelous is trying to identify a date for Annabelle and Julian Huppert to come. So Julian Huppert is our external chair. I think it'd be really interesting actually for the board to hear about the development of that committee and some of the issues that we've looked at so far. So it's helped enormously with a particularly challenging clinical case, which involves other organisations around the region. But they've also looked at issues such as the clinical and health equity strategy. This week they looked at a technological innovation that we have been struggling about whether or not to introduce it into the trusts, and that has been enormously helpful as well. We've got another patient-related case before Christmas, and then we're going to start looking at things like AI and technology generally, because these are areas with quite significant ethical questions that we would like to consider in the trust. So I think it's brilliant, and it's very well chaired by Julian Huppert, and we have some externs, including a professor of philosophy from the University of Cambridge. We've got legal input, so it's really a very, very welcome
Diana Wood is joining
Diana,
us.
she wasn't there this week, but she will be attending her first, hopefully, December.
It's great to have that connection from a former governor as well. Brilliant. We're delighted to see that coming to life. We're now with you, Rachel, for your suite of reports. Thank you.
Thank you. So just to add to Mike's presentation, the quality report is the data that was looked at last committee. I think a few points for me to expand upon. One is that within the report, safeguarding training has required some momentum behind it. There have been two recent days, just to update board, excuse me, there have been two recent days dedicated for full day training for adult and specialist mental health directorate, with 100+ staff in each of those who've been trained. So we should see quite an improvement in that figure in the next reporting round. Also within the report, there are a number, and Mike referred to them, a number of improvement plans that have been working their way through committee previously, where they were identified as an issue. Improvement plans have been developed. These are now being monitored within the directorate, within the directorate specific quality and safety, their own quality and safety meetings, and then up through to our performance and risk executive, and then back through to quality and safety patient experience committee. The important thing is there, I fully agree in terms of learning from those, but it's also about achieving sustainable learning and sustainable change, which the whole basis of that feedback from the directorates is we only get that by engaging at ground level with directorates. So that's a very positive aspect. The one other thing from the improvement report is that there has been a never event, which is explained in there, and that's some excellent work has taken place since that in terms of A, the identification, but B, the learning across the directorate and also with our colleagues in North West Anglia Foundation Trust. And then the final bit that I would like to add, one is complaints continues to be a challenge for the trust. Whilst we've looked at many improvement areas for this, the number of complaints continues to increase, which challenges us meeting that target. There is also discussion within the system, probably referred to the system quality board earlier. There are discussions within the system quality board in terms of changing the targets across the whole system, increasing that potentially to 60 days, but that's being worked through currently. And then just finally, I'd like to say, in line with what Steve spoke about earlier, the thank you week, there was a support workers day yesterday, well attended. Myself and Stephen were there, and I think notably to say a well done to Corinne Armstrong, who's a support worker in our CAMS North team, who received a Chief Nurses Award from Dame Ruth May, who attended and spoke. It was really engaging.
Say who Ruth is.
So yeah, Dame Ruth she was Chief Nursing Officer for England from 2019 to 2023, 2024, I believe. So through the COVID pandemic, she spoke eloquently as always. And again, a thank you to those support workers. It was a really valuable session. So I will end on that.
Okay. Rudolph.
Thank you, Rachel. Can I just pick up on two questions? So one is the rapid tranquilization observations, which is a figure that looks worrying, isn't it? The proportion figure. And you allude to technical problems with the reporting.
Yeah.
Do we have a sense of whether that is a reporting problem or a clinical problem?
It is a reporting problem. So you and Mike did a deep dive into that, and it's the disparity being that there's a time factor of it being reported. So, but that there's, as I said, there's an improvement plan that will come back through quality and safety.
That's one other thing. The sexual safety instance, we sort of report the number and then track them, but I don't have the sense that we split things that are, if you like, within our control from things that aren't. So we would be incredibly concerned if there was a sexual safety incident on one of our wards, for example. But some of these look to be reporting historical events to our staff, which is not quite the same thing.
Absolutely. you're right, and it's the nuance of that. You know, it's not just about our wards; it's also about our community staff seeing patients in their homes, and patients will, as we know, very long time after an event will then disclose because it's impacting upon them now. So, but we still have to.
Other questions for Rachel? I have one. Rachel, just in terms of complaints, I know that across many trusts, levels of complaints are going up. In other places, they principally seem to revolve around people feeling that they're not getting access to services or appointments quickly enough. Would that be true here?
I think that's accurate. I think I would say certainly the increase in complaints that we're getting, many in children's services for ADHD, as an example, and particularly when parents use private services to get a diagnosis, but then to come back into the NHS for treatment, that diagnosis needs verification, which can take some time, and there's a long waiting list. Understandably, very frustrating.
All right. Well, thank you for that clarification. Steve.
Just one point, if I may, in terms of complaints, and Rachel and I speak about these often, and the reason why I think we do is because contained within many of the complaints are opportunities to learn and improve, which is really important. I think the bit that I would say to the board is, though, that certainly over the last 12 months, I've seen a variety of complaints change in their level of complexity. They are very complex in terms of their presentation, the narrative contained within them, and also the referencing that sits within them. Some of our complainants are obviously either being assisted, which is fine, or using other forms of assistive technology to create them, which is also fine, but that does lead to a level of complexity which requires a bit more time to unpack them. Contained within many, there are safeguarding issues, and contained within others, there are levels of either GDPR or data protection that you have to go through. And I also think it's probably worth saying, Rachel, certainly of the last few I've seen that are very complex, they're also multi-agency, which means that it's really tricky to engage with other agencies that are part of that because they have their own processes. That said, we should always keep our eye on being able to respond in a timely manner with anybody who complains. But it is, for those people who do complain, very difficult to navigate, given the complexity of some of the details within it and the things that we can and we can't disclose as we go through a review process. I just want to say thank you.
All right. Mark, and then we must
Do
move on.
we produce a dedicated report on complaints which analyses the mag between the different types, whether it's purely about waiting lists, whether it's simple complaints, complex? Because I think more
it goes through quality and patient experience, and I think that's one of the areas that, excuse me, historically, complaints were categorised as, it's not great terminology, simple or complex. A piece of work that's taken place over the past 6 months is that the majority, I don't think any is simple now, the majority are complex. So we have to reframe that accordingly. And I think, as Steve has alluded to, the interface with our partners across the system, particularly our acute colleagues, if somebody makes a complaint about our services and the acute services, which it might come through site liaison, it could be our district nursing teams, and a discharge. One of the things, certainly from learning recently, was, as opposed to the complaints teams contacting each other through their usual systems, was getting them in the room together, a meeting, making those connections, which has really supported faster resolutions of those complaints. That's a good example.
You do need to move on, I'm sorry. So Rachel, staying with you.
Yes, this is the
Infection control.
yes, thank you. And just to continue your theme, Eileen, in terms of stressing everybody having their flu vaccination, I think from the team's point of view, so there's two things here. One is it's the infection quarterly report alongside the annual report. In terms of our flu campaign, we started on the 1st of October, steadily progressing. We're currently at 34%. We have static clinics, roving clinics, for those services that are harder to reach within the trust. Everybody will be aware that we're, a very geographically diverse trust. We have peer vaccinators in some teams, and also the team has provided dedicated sessions for those staff who may have needle phobias. They've been really well attended and have been very well received this year, which is great. So I just want to say thank you to the team for that. And also, when we submitted our flu plan to the region, it was commended, which is excellent news as well. The only other aspect to highlight is the continued low rate of health care associated infections, which shows a level of excellent infection prevention control across the trust.
I think we want to thank everybody involved in the preparation of this work and all the hard work that goes on. I will still say that 34% is not nearly high enough on people taking up flu vaccine. So let's please keep at it, and all of our staff members who were on here today, either in a governor capacity or observing us, please encourage people to make use of what is a great facility available to them. All right, Rachel, you've got two things essentially for noting, but you just want to explain what they are.
Yes, so first of all, the quality accounts. This is to provide, all NHS providers are required to publish an annual quality accounts. Ours was published on the 30th of June, and this is the appropriate route through to board. Again, just some highlights that I think I would like to highlight is in very good progress in terms of our quality priorities. And also, the board has been told of this previously, but CPFT's first honorary nurse consultant in palliative care, Dr. Ben Bowers, is with the trust, and he was awarded a fellowship of the Queen's Nursing Institute. I met with Ben on Monday morning. We have a regular catch up, and he's enjoying doing his day a week with CPFT, alongside finding it quite challenging getting back into working alongside the community district nurses. So we're working that out, which is great. I'd also just add that I'm sure you've read it, but the ICB noted in their feedback at the end of the report that the trust has been involved in some excellent research and innovation partnerships, which again is very heartening. And the quality priorities for 25-26 in terms of notably improving personalised care is our main priority.
Any questions at all?
I've got a question to go back to the previous report, but it's about the staff occupational health.
Yeah,
Rachel, I'm just wondering, because it's interesting how those figures jump out at you, especially the 3,313, and I'm wondering whether it should be an item on the people and culture agenda in terms of how this correlates to our absence and sickness.
An excellent idea. Looking yourself, Karen and Bree, you're all members of People Committee. I think that'd be good to take.
Yes, certainly. I would add that this is also reviewed in the infection prevention control duty.
Yeah.
Okay.
All right. Thank you. I think good suggestion, and grateful if People and Culture can pick this up. Then you've got one final thing, Rachel.
Yes, this is the CQC statement of purpose. Again, this is a legal requirement for coming through to board, and this is the legal requirement for our Regulation 12 CQC registration regulations that we have to maintain. It outlines the partners that we're involved with and obviously the wide range of services we provide, once again across our extensive geographical area.
This is how CQC knows what they are regulating that we are doing, and it represents a comprehensive listing.
Formality or we
And I ask that everybody is content with this, that we haven't missed anything, if there's anything in there that we don't think we do anymore. I think, after the meeting, if anybody finds anything that we don't do anymore, please let's make sure CQC are aware of that. Thank you. All right, then I'm going to Robert first. Engagement with us as Chief Financial. So with you for the finance report.
Thank you. So I'll
take the financial report as read. I haven't made any significant changes to the way we've presented in the past. The only thing I have done is just in the cover paper, but it's useful to put the financial table in rather than just read the words. That's probably because I'm quite numerate and I like to picture things. But I just want to be clear as to, the position and what we're doing about it. So current position year to date is we're broadly on plan, so we're breaking even. Got to recognise, as the report states, much of that is due to non-recurrent support, and therefore our underlying run rate to our income and expenditure is not where we want it to be. And line is we are not on a break-even position, and what that means is we do have to address our expenditure and make sure that we bring that in line with the income that we've got for this year. I think there are a number of, again, non-recurrent issues and negotiations to be had with various parties to help support that. But the critical aspects are our management of our overall payroll. Payroll, of course, we all know 77% of our operating expenditure. That's key. And I think if we look at the separate integrated performance report, which I will need to make sure that we build in the finance section, we can see some evidence of improvement. Steve, I don't know if you want to add to that before I move on.
So I think what we're talking about there is the drop in bank and agency. And again, if you align it with the people and culture report, you'll see a slight reduction in sort of break last shifts. And you'll see that very sort of green shoots around sort of medical agency. It's slowly sort of turning and beginning to come down. And then we just got through the regional month 7 position against our sort of our overarching plan for 25-26. And again, you can see our substantive workforce is reducing slightly. Our bank and agency are also reducing slightly as well.
So obviously still work to do and a lot of focus on it. I think the other area that wanted to pick up on in terms of the I&E is actually our non-pay. I go slightly off tangent here. We have a very poor better payment practice code. What that actually can mean is that either we haven't got good control of our requisitions, purchase orders and matching of invoices, or good control of our expenditure management. Now, I know there have been a number of issues of learning through the finance department, but this is also about getting calibration and backup decision making and ownership of spend and commitments to those managers that control the budget. So I'm going to have a real focus on that because I also want to make sure that we're not in any way spending funds because people feel we have a budget, which can happen. And actually that we really control, particularly over the next 4 months, those new commitments that we're making, because that's 40 odd million pounds in there. And that's, there's opportunities there to drive that down and make sure we only buy and spend what we need to do. So it's about the commitment management. So I want to get a grip and control on that. I know there are system challenges, but again, I'll be working through the teams to address those. And that's the same for the workforce challenges. I don't think all of our systems are aligned at the minute. We need to really focus on that and support our clinical colleagues with good hygiene factors so that they can do the job easier. So it's not short term, but there are things that we need to do. So I think that's really important. I'm also going to look at where you see the detailed breakdown by directorates. We also have it by executive portfolio, which is good. But the reality, we should have that by actually what the corporate departments are, so we can sense check easier what those are and what we need to do to address those, whether that's estates, facilities, whatever. So we can actually focus on the key areas again of adverse to budget and get that grip and control link in. I think that's really important. So that's that one. Cash balance remains positive, helped by the fact that we've had a payment from Education Department, which is obviously a prepayment, and that will roll through for the next few months, but that gives us in a reasonable position. Capital expenditure, again, slightly above plan, adverse to plan in terms of spending. We do have a lot of commitments, particularly around our business technology, digital, Windows 11, whether it's our new Wi-Fi network systems that we're putting in, which is in excess of plan. And I'm working with the team to see how we can either manage that within this year's capital allowance. And also I'll be talking to the ICB and other partners to see if there's opportunities for an element of slippage, which sometimes happens at the end of the year. But we really have to manage within our original balance rather than hope that somebody will help us with some additional capital, because people sometimes forget capital has a cost. So it's not a free good. That's important. Moving ahead, I think it's also important, quite a discussion around staffing, we do need to really go back to basics, I think, in resetting what we're actually using across our staffing, substantive bank, agency, potential waitlist initiatives, so that we actually really understand and reset by department what we're actually using as opposed to what we'd ideally like to have. And then we can build on those that are in active recruitment, build on those that we've agreed trust board developments. But that's our starting point for next year, so that we can then determine what is the gap between our income and expenditure, and actually then determine exactly what transformation we need to manage that cost down to the level of our income. And I think that's really critical going forward. That'll be one of my key focuses for the next few months, because it is about setting the groundwork. Good turnaround or good control. It's about grip and control at the start. It's not about extraordinary things. It's about actually everybody understanding their role in managing decision making and spending only appropriately. So I'll open up from there.
Thanks so much. Mark, then Steve.
I think once you get a bit further on the table, your confidence levels regarding the delivery of the efficiencies, will we in fact break even with the non-recurrence? Equally, we've had discussions before regarding the need to get recurrent savings, how quickly that can be done, because there's always a lag between coming up with them, implementing them, and then in effect taking effect. And the more the year progresses and we're into next year, then you have the problem of equally next year, you're already on the losing wicket. Again, it would be good to kind of catch up kind of separately on your views on that and how we do progress some of the more fundamental changes or transformational things we need to do, and the time frame that will take in order to get us on a good footing, and also to free up resources where we can then start to invest in things which we all believe would then add to patient outcomes and patient care.
Steve.
Well, it was a similar point, really. Maybe 2 weeks in, unfair to ask you your view on the likelihood of achieving the efficiency targets. You may need more time to look at it, but that was my question, really.
No, I think the danger always is sometimes you actually focus too much on actually what are we saying we were going to do as efficiencies. This is about our overall run rate management, because there will always be other slippages, and we need to make sure that we're capturing all opportunities, not just things we said we would do. Actually, what else is going on? So I'm really, one of the things I've asked the finance team already to look at is actually run rates by department and all of those areas. Obviously, I've said I know there's some system issues. That's not the point. We need to start somewhere that gives an indication. But critically, as a leadership team, not just the execs, but the trust leadership team, particularly through our operational managers, is actually to be looking, as I said, at all of those decisions we're now making about commitments and what we can change, adjust, and amend, so that we're only making commitments on what we can do. And I think then we've got to have an agreement on where we think we've potentially got, shall we say, excess capacity, that we can reduce some of our support to those areas, as well as then making sure we're just pushing every envelope that we can to reduce our cost without impacting significantly on patient care and outcomes, and still managing the throughput. As again, it's good decision making mean better quality of care for our patients. It doesn't mean more cost. It shouldn't mean you're taking out the waste and using the resources properly. It takes time, but we can do that. I also need to get the link back, which is really critical, from a position where you've got a relatively young, immature finance department, where people think that's where the money's spent. It isn't. We know the decisions are within the organisation. It's there that will influence the control and the grip and the right decisions. So I will be working very well on that.
All right, thank you. I think it is just worth noting that if the Secretary of State for Health and Care were here, he would be saying it is non-negotiable that we have to break even. It's our responsibility as a board to make sure that we deliver on our statutory duty to do it, and we will never compromise on patient safety or care, but living within our means is a not unreasonable ask of a public service body. So we've got to deliver, and we will treat this with the seriousness it deserves. Okay, I'm going to go to you, Pri, now to pick up on the people and culture matters. We do need to get the pace.
Can I check you can hear me? I'm having some sound issues.
Okay.
Can you hear me now?
We can hear you, Pri, but for some reason the boardroom's been muted.
Okay. I don't think I have the power to do that. The boardroom is muted, which may not be an issue, but as long as you can hear me, I'll carry on. Is that okay, Chris?
Yeah, we can hear you, Pri. We might need someone in the boardroom to just click the unmute button on the device.
Chris, do you want to stick something in the chat box? See if...
The chat is turned off, but I will contact Martin. I'm actually sorting it.
Can you hear us now?
We can
I
now.
can hear you. Sorry about that.
Right, okay, Pri, on you go.
Fine, right. That was all the good stuff. Right, I'll start again. I will take the report as read. We've had 2 committee meetings since the last public board, just because of the timing of the meetings. We have discussed a number of different things. There have been some ongoing discussions about the risks to staff where they're required to physically intervene as part of their role. But we have now seen a significant increase in the training compliance, which we will take as a metric that hopefully staff are safer, but we will continue to look at it and look at the risks surrounding that. There were also some concerns about safer staffing levels. We were held up on that by the appointment of a member of staff to look at that. They've very recently started, so we'll look forward to that coming back to the committee as well in terms of the risks and hopefully start to mitigate some of those. We did note that there has been an increase in the number of employment cases, the majority of those concerning sickness. As a committee, we take a view that it is obviously helpful that staff are being managed well, but also concerning that the levels are increasing. And again, we will continue to discuss that and look at the levels. There will be a change in January regarding agency usage, especially around some band 2 and 3 roles. And so that will come back to the committee at that point and we will discuss it. We are encouraged by the continued use of the staff wellbeing service, and we are aware from feedback that that can have a very positive impact on staff wellbeing and also in terms of the trust's ability to perform and its resources. It can either hasten people's return to work or avoid them needing to take time away from work. One of the questions that we had raised was regarding the restrictions on use of agency staff and whether that was impacting other staff's ability to complete training and take part in learning interventions. And we did receive a presentation about that, and there has been no demonstrable impact on that. We talked about freedom to speak up. We are still encouraged that staff are speaking up, but we are also conscious that we need to triangulate the data that comes back to us with different sources of data to make sure that there is learning and also that staff are engaged with the Freedom to Speak Up service. And also we will liaise with Mike and escalate things to the Quality, Safety and Patient Experience Committee where it's required. Just very briefly, I'm conscious of time. We talked about shaping our future together and the positive impact of the behaviour framework, but we will need to see evidence that that's impacted positively on the culture across the trust. And 2 important things to finish on. We discussed racism, including anti-Semitism. We are assured that the trust is acting to protect staff, but it's something that we will always talk about. We will always support staff. And I do just want to extend the committee's thanks to the staff networks who do perform a really valuable role for the trust. And a positive to end on, which is the trust is due to sign up to the Care Leavers Covenant. So that will provide support to 16 to 25-year-olds in terms of future employment and the ability to live independently. And I'll stop there, Chair. Thank you.
I'm delighted to hear about the last item, such an important area for us to be visibly supporting. But I think all the things you draw out, and particularly the anti-racism and anti-Semitism items, are critical to ensure that the board's position on this is crystal clear. We do not tolerate it, and we want to ensure that people have the very best experience of either receiving care from us or working for us, and that is critical in respect of such things. Any questions or additional comments for Pri before I invite us to move on. All right, thank you. Critical committee, particularly we're asking staff to do so much just at present. So we do need to make sure that that you have a good sense of an underlying workforce strategy and people plan to support this. Stephen.
Thank you very much, Chair. So the data we're using in this report is the data that went to the 15th of November P&C committee. So just to build on just a couple of points that has already raised around sickness. We are seeing that increase in sickness, and we've seen a slightly higher level of sickness during the last year. You'll recall in the long-term plan, it talks about reduction of sickness from which is the NHS average of about 5.1% down to about 4% just over. So again, that narrative, that conversation we had earlier on around flu and sort of getting your flu vaccine, et cetera, it's really, really important. And what we've also agreed to do, which I think aligns very much to where Jackie was coming from earlier, is to do a deep dive into the sickness. And that will also include, you know, the occupational health support and that sort of thing. So I think that just brings those strands together. So that will be coming back in January, which again, I think is important for the board to be aware of. And then just a couple of other sort of important areas, and I've already referenced sort of a slight reduction in sort of medical agency, which I think is sort of important sort of green shoots. And then finally, we've seen turnover decrease. And again, it's now at its lowest level it's been for a number of years. And again, I think we'd also recognise the importance of trying to reduce our turnover. And apologies, my final point is we're currently in the middle of the planning round. And there will be an overarching sort of workforce plan coming to the next P&C committee, which will take up quite a chunky bit of that narrative and that conversation. And I'll stop there and answer any questions.
Can we also just remember, for the benefit of those who are with us, not to refer to committees by their acronyms, because although we live and breathe them, it's important that people consistently know what we're talking about. Stephen, just on the workforce turnover target, we've got a target of 10.5%. And my question has consistently been, do we really want that target?
It is very much in our gift to review the target, and we may want to pick that up in people and culture. When we last reviewed it about 5 years ago, we did look nationally and where the other organisations were. Where was the national sort of turnover? What was the best practice around this? And we came up with that sort of 10%, but it is in our gift to look at that as well. It's not a nationally prescribed target.
I think there's 2 points, if I may, Chair. I think one is I think it's a good question in the sense of the turnover. I think working through the committee, though, one of the areas is where is the turnover is as important as the number, because I think if we break that down into either staff group, locality or area, it will give us a temperature check against culture or behaviours. So I think that percentage is important to look at, but I'd also urge, I think, a curiosity in terms of how that's made up. I think the second point, while I've got the microphone, is to pick up on Pree's point around anti-racism. It was really good to see the Race and Health Observatory come to the confidential board to talk to us about plans moving forward as an organisation. And I am delighted that we are going to be working with them as a partner to try and support both initiatives in anti-racism and diversity in the organisation, and explicitly moving away from being an organisation that, how can I put this politely? There's a fundamental difference between being a not racist organisation and being an anti-racist organisation. And Habib, who's the chief executive of the Race and Health Equality Observatory, has offered support. And I know that we'll be starting that programme of work through the latter part of this year and into the early part of next year, with a real redesign and focus on the word culture for the organisation. But that means a lot of things to different people. So I think we need to put that as part of a fundamental underpin to our strategy that's a bit further on in the agenda.
More questions for Stephen on what is quite a detailed report, noting that some things are going to go to people and culture committee for some slightly deeper dives. Right.
The only additional point I would make is that the equity strategy, which we've already talked about, talks about not only equity when it comes to patients and carers, but also staff. So there's an overlap between the Quality and Safety Committee and the People and Culture Committee. So they work on EDI.
And I think, sorry, I think that's really important. And if you think about that sort of the anchor institutional social value, I mean, there is a read across there. So again, the care lever, I think, is really important in the work with the Prince's Trust, etc. So it's something that we can build on, but yes.
All right, I'm going to have to move this along. Steve, with you, the yearly review of service.
Thank you, Chair. So take the report as read with a couple of highlight points. I think the first is thank you to everybody that's been involved in service visits. It is often something that is good for some people and not good for others, and we have to be very careful of that. And the reason why I say good for some and not for others is because I focus on section 5 of the report, which is maybe really good for us to exhibit curiosity and engage with our workforce, but we have to make sure it works for them too. We have to make sure that our workforce values it, understands that this isn't instead of our existing reporting and escalation processes, but this is a real and genuine curiosity and reach in by board of directors and everyone around this table to make sure that our workforce knows that we are interested in what they do and value it. And the feedback in there is really important because although that's a snapshot, it's a very positive snapshot. A bit of the less positive feedback has been that sometimes we have to be mindful of how much time we take in clinical services when we are attending. Sometimes we might have to rearrange those if acuity or there is difference in the team, and therefore not just turn up if there is a problem. We need to be very flexible, particularly those of us that aren't working in that space. And a great example of this would be if you go and knock on one of the wards door at the moment, then they may be very willing to see you and very happy to. But if there's issues that they need to manage there, then that's their priority. So I think everyone around the table would take that immediately. 57 visits completed, which is excellent across a variety of our services. I think it's right to say that we should continue to do this and more if possible, because our workforce does appreciate it. But I would like to offer the board some assurance that I don't think it should just be us that does our service visits. It should also extend into our senior leadership teams and our directorate leadership teams, including some of our corporate officers. So some of our people that sit at associate director level are in a corporate service. It's really important for them to go and visit services too, because they will get a real sense of the fact that they do a job that enables and supports our clinicians to do their job. Not to embarrass Robert, I don't even know if Robert knows, but one of the accountants reached out to me a couple of weeks ago that said that he was organising with some of his team a shift to do a healthcare support worker role in some of our wards and departments because they were curious as to what their input was and how they could help at a clinical level. That hits me straight in the heart because that's brilliant. And I think if we extend that to all of our senior leaders as well as some of the people who are just curious, the more we get closer to the business, the more insight we get. So the report is there for noting, Chair. A lot of good work, a lot of feedback. The one thing I will say, actually, sorry, in terms of the thematic feedback, you'll see with open actions compared to closed actions. I'm going to say I'm pleased to see, but that's the odd way of saying it. I'm delighted that the open actions are the more complex issues. And the reason why I say I'm delighted is because they're issues sometimes outside of our control. The closed actions are those where people have raised a concern that's been dealt with and dealt with quickly. We have to be careful, but what we don't do, though, is create a second route for our workforce to go through rather than raising appropriate roles, jobs, requisitions, planned approaches. But at the same time, we should also be equally curious if they've been waiting for an action for a long period of time to hold a mirror up to ourselves. So thank you for everybody that's been involved and long may this continue.
And a big thank you to some of our governors who are with us today, who give their time and add such value to service visits as well. So Steve, sticking with you, freedom to speak up slightly in this report.
Thank you, Chair. So this is the biannual report, 6-monthly report around freedom to speak up. I know this gets reviewed at the People and Culture Committee, and I know there's a lot of discussion in terms of both the thematic findings within here, some of the data that's presented, and also the crossover with a lot of the freedom to speak up into some of our more formal policies and procedures. There are two things to note in the report. The first thing to note is a significant thank you to the Freedom to Speak Up team for being visible and engaging with our workforce. The second thing to note is a thank you for them to understand and take on board the feedback that was gained from our CQC well-led review, where our workforce raised their insights into how this works for them. And so I think the team, Annie particularly, and the team taking that on board and looking to modify this so that this becomes a process where people feel safe, psychologically safe, and able to manage this is really, really important. And that's part of our CQC well-led report. The second point to note here is also an evaluation against having our Freedom to Speak Up data benchmarked against our national benchmarking information. That's where I made reference to the model hospital data. There are some areas in here that look like they are outside of those benchmarks. Some of that may be down to reporting, some of that may be down to coding, but we just need to be curious about that and ask ourselves why we are out with, in with, or outside of our peer benchmarks, which is super important when we start to get into this. There is one note of the report which would be remiss of me to pick up. It was picked up with some of our governors. Thank you, if any of you are on the call, with relation to our training around freedom to speak up. There are 3 levels of freedom to speak up training. Level 1, which is part of our really important being aware of and part of our mandatory training side. Level 2, which is for people in a more senior role, and level 3, which is senior management. And you'll notice that there is a low take up in the level 3 area, but the compliance against that is due by the end of the financial year. And I've written to all staff, certainly the TLT, as we call it, our trust leadership team, to engage in and comply with that level of training. I did it myself and it doesn't take long. So I think the statement I'll be making to our senior leadership is, if it's worth doing, then you should do it. And therefore we should give feedback if it's not worth doing or if it doesn't add value. But quite frankly, it was very informative and it was very good and easy to do. So I think it will be a message that we give out. So thank you to the forum for raising that. And Pri, thank you for saying that you would also pick that up through the People and Culture Committee.
Brilliant. It is always difficult to make time for training. We all struggle with it, but having just gone through my own batch of things that were coming up for renewal, you will learn something in everything that you do when you do it. So I would stress the importance of it. Mark.
I haven't had the pleasure to start the training yet, but I'm sure there's going to be a backlog pretty shortly after the induction. Do we on the training courses actually ask feedback electronically? Yes. Because that's sometimes useful of, are you getting the right message across? Is it the right length? Those types of things can be useful for then the future development of training.
And you're allowed to complete it, so given feedback.
It's feedback on feedback.
Yeah.
Yeah, it's through the academy route. So the digital academy, I think you'll, I'll check with you, you've got access to it, particularly now you've declared that you might not be compliant.
All right, on that happy note, joking aside, being able to speak up is a sign of an organisation that is healthy. Yeah. And that is the sort of organisation that we want to be. And we know that people have spoken up historically and we have acted on it. That is, again, what good organisations do, even if it is difficult and sometimes uncomfortable. Stephen, you will have to be brief.
Just to say this is really important because actually, it's not nationally mandated around the freedom to speak up. And actually what we're doing here is actually driving this nationally. So that's the level 1, level 2 and level 3. So we should recognise the importance of that.
Well, I think, as I say, we're an organisation that has very visibly dealt with freedom to speak up issues, and we will always do that because it's the right thing to do. Steve Cox, we now go to you as we move into the business and performance matters from the Business and Performance Committee.
Thank you very much. I'll take the report as read and I shall be as brief as I can given time, but also many of the items we spoke about at BNP last time are on the agenda anyway. So finance we've already covered. So we had a good discussion based on the month 6 report at Business and Performance in October. Really good discussion earlier, and we'll look into the detail of month 7 when we get to BNP meeting in December, and to work with Robert on describing the wider run rate will be for us to do. We did give limited assurance, it's important to say, in October, so we'll be working hopefully to improve that rating next time around. There are 3 items coming up on the agenda, so I won't go into detail. So the green plan Fulbourn Greenway and the emergency preparedness assessments were three that we recommended come on to board. So the Business and Performance Committee were supportive of each of those. And I should just say on the emergency preparedness item, it says in the wording partially compliant, which in our own sort of language maybe isn't seen as particularly positive, but it should be seen as very positive in this sense because we're very close to being fully compliant. You'll see that in the paper later, just two actions to complete on that. The only other couple of points, the one that we highlighted as an alert in the paper is around digital maturity. We're in the lowest 20% nationally, so there is work to do for us on that. That's despite a relatively high spend. And I know that the Digital Transformation Board and the strategy that's being prepared will be addressing that, and I look forward to seeing progress shortly. And one other on risk management. We spoke in the item on the operational risk register about the cybersecurity risk retaining a high score of 20. Maybe that is something we can't influence hugely, but we did agree that there will be more detail come back to us next time on the mitigations, and we are able to put in place and affect that score. So I think that's all I wanted to say.
No, thank you. And I think I'm sure the board would have taken on board the view of the committee that at the time you met, the limited assurance on achieving the improvement plan is something we need to be very alive to. Any questions at all for Steve?
Just a very brief one, Chair. Thank you for the reference back to the EPRR, Steve. I think there's a piece of work that the board may not be fully cited on that I was presented to me called Operation Cavell. I don't know if you're familiar with this. It's against the Edith Cavell rather than the Cavell Centre, so it's really important. The namesake here is really important. Operation Cavell is a national initiative that the Trust has taken great strides in setting up around supporting some of our workforce that does unfortunately come in contact with people that are either abusive, racially assaultative, physically assaultative, or verbally assaultative, and it's the way in which the organisation responds to that. I think it's with your agreement, Stephen, with Chair's agreement, it's something that I think needs to go through BNP because it's an excellent piece of work and something that we need to celebrate around the table because it is something that demonstrates what we are doing to support our workforce when things get difficult for them. So I did see that, and there's a huge amount of work that's gone into it. It's very, very good. But I won't take any more time, Chair, just to land it in the EPR space.
Okay, thanks very much, Steve. Holly.
Sorry, could I just say, Steve, just for your information, that does come through quality, safety and patient experience as part
Right.
Quality and safety report in terms of the estates report. So just to make sure that is noted.
Thank you. Yeah.
And Steve, one thing I would be grateful if you could pick up on and then bring back to this board, it's about the digital maturity. We do spend a lot, and to be where we are assessed nationally is not good enough, and it does impact on our ability to be as effective and efficient as we would want to be. And for a trust that is as innovative as we often are, I think it's a great shame. So we need to do more. So I would just see if you and your committee could give that a little kick around again and then bring it back as a board item. Sorry, Rudolph, and then we must move on.
Just to on that as well. So I am not sure I quite understand in what ways we're spending this, because you can cut that digital spending in different ways, and I don't know where we sit. But we're also aware that the digital strategy has to underpin the clinical strategy, and that has a fair focus on digital improvements in clinical care and productivity. And I suppose the area where I'm perhaps most concerned is the staffing of the teams that have to do it, because when you don't have enough teams and they're losing, I think, 5 people over the next few months, and it's a very small team, they're the team that has to support these things wherever we implement them. So it's great to have some more focus on that.
Okay, well, I think we need to keep coming back to this one, Rudolph. Right, can we move on then, Holly, to the operational performance report? I'm going to ask you to be brisk on this.
Yes, thank you, Chair. First thing I'd like to note is that in the last 3 weeks, we've welcomed Sue Graham as our new Ops Director for our Adults and Specialist. directorate. And so that means that first time in 12 months, we have a really substantive operational director team, which is great news. And I think even in this short space of time, we're seeing them really working well together and providing that focus. In terms of highlights that haven't already been discussed from the operational performance perspective, I'd just like to highlight the positive work on over 52-week waits in community services. That's part of our national oversight framework metrics, but most noticeably in diabetics and community paediatrics. So although both these services remain challenged in terms of demand, diabetes have reduced their over 52 waits from 61 to 6, and community paediatrics have reduced theirs by over 50% and have a plan by the end of December to have eliminated over 52-week waits. So that's really positive. Directorates obviously continue to identify and deliver efficiency schemes both in year, but we're also trying to look at identifying the transformational schemes for 26-27, so that we're trying to get ahead of the game. I think the other area I'll pull out is around our crisis response performance. So again, in the National Oversight Framework, we identified that performance was lower than we would like, but also we didn't feel that it reflected actually what our clinical teams were telling us. So we've done a deep dive into that and identified some recording anomalies, and we've worked with teams in both adults and our older peoples, and are seeing improvements in reporting, which better demonstrates our performance, but it will also be reflected in our next month feedback. And then just to highlight that in terms of our patient and care and race equality framework data, we've identified 2 areas for initial improvements. First of those is talking therapies, which is showing that the recovery rate for BAME patients remains below target, and the other area is our physical health checks for patients with severe mental health illness. So whilst high overall, it does show ethnic variation. So the relevant teams are focusing on those 2 elements to better understand that variation, and then obviously develop initiatives to reduce that. And while Steve has already mentioned the colleagues and teams who've been nationally recognised, I also wanted to just recognise those because it improves patient care, but also supports our performance for our national oversight framework.
Thank you, Holly. Any questions at all on well, it's great that we're a full complement of substantive staff in the directorates. That is brilliant, and I'm sure that will start from a quality. Can I then go, Jackie, to you for the head to toe?
Thank you, Irene. We had a meeting a couple of weeks ago, and I think the overall reflection of that meeting was that we are now seeing signs of consistent maturity of this charity, evidenced by the stabilising of our financial position, and the head of charity is reporting that we will actually exceed our target set for this financial year, including pledges and commitments. We have rebranded, and that's not just about a logo, but actually it's about what the charity stands for, and that's starting to be crystallised and working in partnership with the trust to ensure that the priorities for the charity align to the emerging strategy of the trust. And the branding has actually gone down really well with staff. We're seeing now some consistency in the delivery of projects, which is great. And I would like to personally thank the charity team and Chris, who is on the call, for his leadership and for Hannah's leadership across those projects. We are also starting to forge ties with the Children's Hospital, the Cambridgeshire Children's Hospital, and they are now actively involved in making sure that the two major charities, ours and ACT, are joining together. And the last bit, and I would be remiss at this time of year not to say, but Hannah and her team have pulled together a list of festive activities. If they've not already been circulated to the board, we can do so. But they include raffles, present wrapping, and joining with other partners like Heart and Soul and the Salvation Army to do some carol singing across some of our buildings and estates. Oh, and there's a school choir. So as the chair of the charity, I think we have had a really great year, and we are setting ourselves up for next year. The final part is that we will be bringing back to the CPF, well, the Charity Board of Trustees, should I say, our annual report. And again, I would like to thank Kish and the finance team for moving this along at pace and in a timely way.
Jackie, there's lots going on, but I think we should say thank you to you. You've made a tremendous contribution to head to toe during your time chairing, and to Hannah and the team for all that they are doing. But also to congratulate you and thank you, because Jackie is going to take a seat on the Children's Hospital fundraising committee as well. So it would be great that you are there also. Thank you. So let us move on then to you, Mark, for the Audit and Assurance Committee.
There's been one meeting since the last public board on the 8th of October, which Brian chaired as he's one of his last duties. We had presentations from internal audits and 14, as well as on board assurance framework, which we've already covered, and operational risk. On the audit side, there was one report on board assurance framework, which had reasonable insurance, and also cyber security kind of a framework audit, which there was a high confidence rating. So I think, positive news there. There is a question mark regarding the timeliness of completion of actions. I've now agreed with internal audit that they'll share their draft reports a month before it comes to the board, to the meeting. So it gives me time then to follow up with people on any kind of outstanding actions. On the alert areas, operational risk, again, there was a good report, and we have reasonable assurance levels regarding the reporting. Again, the issue is more the timeliness of completion of actions, as well as the training of people on risk matters. So I'm scheduling a meeting with Jim Ledbetter to go through what can be done on the training side, make people more aware of what they need to report from a risk perspective, but also how the need to close actions on a timely basis. Equally there, what my aim is to get more details on actions when they're due, so I equally can follow up as chair, and equally sometimes call people before the committee to ask why something hasn't been closed, or what's the delay in closing it. The other alert item is the standing financial instruction waivers. There's a partial level of assurance there. The issue is more, are we sure it's complete? So all of them were coming through to Kish, and he was signing them off, but other things which we're not aware of, which should be reported. So it's really the completeness where we were concerned, and why we gave a partial. So I'll be following up with Robert of what can we do in order to make sure that everything which should be coming and being formally waived is being coming and being formally waived, so that we can change partial to give us a greater level of assurance.
Brilliant.
So that's a quick summary.
Any questions at all? Robert, I'll have to be brief.
It'll be very brief. I think Mark and I'll have a discussion, I think, as to what I need to be doing and what he needs to be doing as a NED for assurance, because I think some of those actions are quite straightforward. That's the finance director's responsibility. So I need to make sure that I'm following up on behalf of the execs, and Mark's holding me to account on assurance for doing that.
Brilliant. I'm sure you'll work it out between you. What we actually want is assurance that everything done. So therefore, it does need to make sure.
I'll retire from that role, and that's
not too quickly.
No.
All right, Steve, Children's Hospital Committee.
Yeah, again, I'll be brief. So the report is from the last meeting of the Children's Hospital Committee on 28th of October. The full business case is where we're heading with the work streams at the moment, and submission we subject to sign-offs should be in September next year, submission to government of the full business case. The work stream leading to that set out in paragraph 2.4. Just to flag a couple, you'll recall the discussion we had, some NEDs had and others have had in the summer on the joint venture, which is the joint venture that CPFT would become part of for the design, build and maintenance of the building. We raised a number of issues at the workshop we had in the summer, and we want to follow those up before the JV comes back to the board for a sign off. So we are still looking and waiting for the next follow-up workshop. It's been raised, I know, with the programme director. He's aware that we want that to happen in the spirit of let's get these things discussed and sorted before we so we have plenty of time before we come to a formal decision-making forum. So that's important for us to see and for that workshop to put in the diary as soon as possible. And the JV itself, timelines have slipped by 3 months. It won't affect the overall timeline for the FBC submission. So the decision that will come to the board is likely to be March, April next year. The joint endeavour work, which is looking at essentially the operation of the hospital once it's up and running, has been work done by an organisation called Stratis on behalf of the partnership. That work has been, it's a final report. I know execs are looking at it. We'll get an update at the subcommittee meeting in a couple of weeks' time. And then I think it'll go away again and be looked at before coming back to the committee and then to the board early in the new year for a decision. And that's again really important, has implications looking back into CPFT. So it's really key that we have the time that we need collectively to look at that. Only other thing to say, detailed design work, really positive. Design work is now happening through the contractors with our teams and other teams in shaping the building and the detailed design of it, which is really positive. So yeah, works progressing. I don't know, Kathy, is there anything you wanted to add?
Nothing really. I just the joint endeavour draft report will go to execs, we hope, before it goes on to the subcommittee, because there's a huge amount of detail in there which I think we need to consider.
Well, both that and the joint venture need to be considered very, very carefully. This board, Steve, and then we must move on.
I think we'll take this offline, Chair. I think, Steve, conversation would be really helpful in terms of working backwards from a decision timeline for the JV, particularly because if there is a delay in the workshop, recognising diaries will be busy and things are complex, we mustn't allow ourselves to walk into a space where we only have a week or two to turn something around. So if there is an issue of if that needing escalating, please let me know, and between you and Kathy, I can pick that up on our behalf.
Be absolutely clear, we're not going to be rushed into any decision on this. All right, now we've got 3 strategy items, and I'm going to suggest, Stephen, that the trust strategy, the overarching strategy, is one that I think everybody in this room, almost everybody who has joined us today by way of governors, will have had some engagement and involvement with. So I'm going to ask that you be brief on that, because the 2 which have had engagement, but perhaps not quite as much, the health equity strategy and the clinical strategy, I would like to give the great portion of time to. So let me go to you first.
Thank you very much, Chair. Well, absolutely. So just to sort of align to that narrative, this is papers coming here to note the work on the strategy. And as you'll see, there is a sort of a timeline. There's a 3-phased approach. We're in the last phase. Our expectation is to bring this to board in January. We're now going out across the system to both local authority, ICB, etc., in order to make sure that we've got sort of broad sort of buy-in and engagement from a system perspective. We've obviously done board development, and we've also done wider sort of council of governors, and obviously you can see the amount of touch points we've done across the organisation. And then finally, you can see the emerging strategic themes. These are not set in stone. They are still developing, so they may look slightly different once we get the sort of the final product, which we are currently working on, and we should be sending that out towards the end of this week for further consideration and discussion And I'm going to stop there and answer any questions.
The colleagues, clearly something's still a little bit of work to do, but the core themes and the engagement have been well worked through.
Just very briefly, I think when the board sees this in January, what Steve and I will try to do is to also show you where it dovetails into the new planning that's coming out really quickly. That's the 17th of December, followed by a January iteration, followed by a February iteration. So the document that will land for the strategy will contain that, but we'll show you where the bridge is.
So I will say this in relation to our overarching strategy, but all other strategies, they are as good as the traction they're able to get with the people with whom we work. So we do need to be really, really clear that it's great to have been able to pull all the thoughts in and the thinking, and the distillation is brilliant, but it's got to feel real, it's got to feel relevant, and we've got to find ways of actually getting people to engage consistently with this in terms of shaping how they work or how we co-produce services together. It's got to feel real. If it doesn't, then it will have been quite a time-consuming exercise and no more, and be better than that. So can I just make sure that we keep coming back to that, Mike?
So, yes, I agree with that, and I think part of the presentation in January, I don't know whether Chris Walker would have something to say on this, but as part of embedding this in our organisation, the comms around these strategies is kind of critical. People need to know A, it's there, and B, what's in it, and what does it mean for them. And so it will be helpful for me, I don't speak for everybody else, to have that sitting alongside the actual document.
And to say, Chris has already started to work on that, and he's done a very nice little video for the clinical strategy that we're just going to modify. And he's also going to do one for the health strategy. So that's
as if by magic, I think Chris wants to come in. So in you come.
Thank you, Chair. Yeah, thanks, Mike. So just to reassure, we've got sort of 3 or 4 separate plans now in terms of launching them across the organisation. But I think the key thing is that we're not just going to go for the sort of straight launch. We want to make sure that we're doing engagement prior to that as well. And that ties into the kind of final stage of engagement that we've got scheduled for the main trust strategy. But as Kathy mentioned, we're not just going to be putting out sort of normal written comms. We're working on easy read summaries. We've got some little videos that we'll be able to push out as well. And really, it's just like you say, to make sure that it's speaking to everybody across the trust and to patient service users and partners, and it's not just a static document that we push out and then kind of don't continue to talk about. So happy to share some of those assets before the main launch, but we're just trying to think about how we do this a little bit differently from how we've done it previously.
Okay, well, I would assume that everybody who sits around this board will want to be part of getting behind this, Chris. So if you can think about how you can use all the assets here to get people out, get different voices heard, we would love to be engaged in that. It's really, really important to us. So let's, Kathy, go to you, because under you sit 2 really important strategies for CPFT, which we as a board have given a significant amount of time to. But I'll just give you the opportunity to talk to, firstly, the health equity strategy.
Chair, with permission, if I could put them back to back, because they're companion strategies. And essentially, the clinical strategy sets out what we want to deliver over the next 5 years, and the health equity strategy then sets out how we will ensure that every individual has the opportunity of benefiting from that. So before starting, I'd just like to highlight the pivotal role of our public health team. So Catherine Faulkner, who is supported by Hannah Roscoe and Becky Best, 2 registrars. So they've been absolutely fabulous in helping to develop these strategies. So both strategies are underlined by a very simple mission, which is to improve the health, both physical and mental, of our population and to reduce health inequality. So a very simple aspiration, more difficult to implement. So if we start with the clinical strategy, so this sets out a very clear and very practical framework about how we will deliver high quality, consistent and equitable care over the next 5 years. Going to your point, Chair, about engagement, it's had extensive engagement in terms of developing it. So we have inputs from a variety of sources and methodologies from 1,500 service users and carers, as well as 250 members of staff. So lots of focus groups, surveys, etc. And there's great consistency between what people want. So patients and carers want easier access, more joined up care, and they want trust to be more responsive to what matters to them. Staff want clearer pathways, better use of evidence and systems that support them to deliver high quality care. And the strategy has been developed in the context of the local and much broader NHS landscape we find ourselves in. So as we all know, we serve a population of 1 million people, but there's significant diversity and marked health inequalities across that population. Demand is rising, complexity is increasing, and resources are constrained. So a fairly challenging environment to develop a strategy in. But against that, we've got very clear strengths in the organisations. We've got our academic partnerships, we've got our multidisciplinary workforce, and we also have our system role as both a mental health and community provider. So we're in an excellent position to support and lead on integrated care. So we've got 3 clinical priorities. The first is evidence-based treatment and support. So improving consistency, reducing variation, expanding access, and using outcomes to understand our impact. Treating the whole person, and this goes back to something Mike Napton said earlier. So not just focusing on particular areas like the Children's Hospital. The Children's Hospital shows us how far we can go in terms of integration, but actually looking at all our services. So we've got our fantastic community services that provide stellar physical health. We've got our mental health services, and we really are in a position to bring those together in a much stronger way and embed prevention and also improve transitions. And then fair and equitable services is our third clinical priority, restoration and other inequalities. Along with those, we've got enabling priorities 4, so strengthening clinical leadership, aligning services with neighbourhood and system partners, making better use of digital tools and data, and embedding research, innovation and quality improvement in practice. Just to say that the strategy aligns with national policy, including the NHS long-term plan, but implementation is a real that's where things become very important. So as Chris said, we don't want a strategy that sits on the shelf. We want something that actually makes a practical difference. So we've already started to develop a high-level implementation plan, but also we have a number of enabling strategies. So Ben is here today. He's appeared and is going to give us a session after this on the R&D strategy. We've got things like the digital strategy, our operational plans, etc. So all these need to align with the clinical strategy and the health equity strategy. And we need high-level support as well. We need board visibility and board support for the implementation. So obviously the public-facing strategy, which is what you've seen in the pack today, is quite comprehensive. But as Chris said, there will be a short version for staff, easy read versions, and also, as I said, that high-level implementation plan. So that's really a summary of the clinical strategy. If I come on to the health equity strategy, so this, as I said, is how do we make sure that the benefits available through our clinical strategy are available in the same way to every single person in our population. So just a bit of background. So people don't always fully understand what we mean by health equity. When we talk about health equity, we're talking about access, experience, and outcomes. So we want everyone to have equal access, equal experiences, and equal chance of good outcomes. And if we look across Cambridgeshire and Peterborough, we've got some really stark contrasts. We've got children growing up in severe deprivation. We've got some of the most socially deprived areas, which people are always very surprised about. So if you look at East Cambridge, and only a few miles away from some of the most affluent areas in the UK. We've got racialised communities, particularly in Peterborough, facing some of the poorest outcomes. And we've got people with severe mental illness dying 15 to 20 years earlier than the general population. And that's not just a national figure. In fact, Rudolph has actually done a piece of work on this, looking at our local population. And then if we just come to CPFT, we've got inequalities that we know about, some of which we talked about today. So the lack of a psychiatric intensive care unit for women, meaning that they're sent out of area when they're at their illest. The lack of ACT provision in the south, meaning patients need to travel to Peterborough for what can be a potentially life-saving treatment. And the fact that Black people are more likely to be detained under the Mental Health Act, which is a national problem, actually. And these differences are not inevitable, but they are avoidable. But we need a coordinated response, and some of those interventions sit within CPFT, but also many of them need a wider system level or national change. Again, we've had a lot of engagement with staff, service users, carers, community partners in developing this strategy, and it aligns with the long-term plan. Also, for 420+5, the Marmot principles and our ICS priorities. And our focus in terms of our framework, there are just a few summary points I'll give you. So firstly, we tackle racial inequality head on, and a lot of that will be done using our PCREFT framework. So PCREFT stands for Patient and Carer Race Equality Framework. We will remove barriers to access and make our services more culturally competent, trauma-informed and neurodiversity friendly. And a lot of that has been done through the Culture of Care programme. We'll strengthen reasonable adjustments, and this comes into the clinical strategy, focusing on personalised care, and we will focus on preventions, particularly in our highest risk communities. And then also we wish to maximise our impact as an anchor institution. So many inequalities arise from social determinants of health, not just only about 20% of that is related to health services. So we will create social value through our employment, procurement, and partnership with local communities. And we have a clear sort of set of outcomes that we want to report to the board on a regular basis. But as with the clinical strategy, success depends on sustained leadership and commitment at every level. And I'd actually like to give a shout out to Steve Grange, because he's really driven from the moment you've arrived in the trust this whole issue about making sure that we are in front of all of this and striving. I think I'll leave it at that and open it up for questions, but I think it's very exciting. And as I said, we're looking for approval today.
And I noticed that we've got Hannah online with us. Hannah, you're very welcome. Thank you enormously for all the work you did. So I've been asked to approve the clinical strategy with all the issues of health inequality behind it, which Kathy has outlined to us. Anybody want to do anything other than welcome this work, Steve?
I just thank you for the thank you, and a thank you back to the thank you. There has been an inordinate amount of work on this, and I just put a small challenge in, and Hannah is online with us as well, and I think Hannah and the team have worked remarkably in a space where there are not many providers that have committed to a clinical strategy, and I think we should just pause on that for a second. There's a number of reasons for this. One is it takes a significant amount of insight. Secondly, it takes a huge amount of data and information to be informed, and engagement and co-production. And then thirdly, it takes a lot of courage to nail down some of the areas that you're focusing on trying to address, some of which are within your gift and some of which are outside of your gift. But our very nature of being here means that we should influence everything around us as being a good corporate citizen, about being associated with the Marmot principles. And so when you read these two documents side by side, this is a bit of a milestone for us as a trust. In fact, arguably, I'd go one stage further and suggest this is a real core demonstration of our commitment to the delivery of the NHS plan and its remit. There are not many providers that have done this. In fact, I don't know hardly any. So if you do wish to check out a clinical strategy and see one that's written really, really well with no bias whatsoever, read this one, because this is one that's been put together. I am very pleased to say that I have a meeting with Professor Sir Michael Marmot in a couple of weeks to talk about accelerating this into the organisation being recognised as one that is passionate about those key determinants of health and the Marmot principles. So hopefully with some good news and some support from those around me, we might be able to get the organisation to be recognised as a Marmot Institute, because it's right to do so. And I think this is just something that we should be really proud of, actually. And I think Chris has done a great job in terms of helping us communicate this to all of those that have been involved. But now is probably the time to also be bold to the outside world and demonstrating why we believe this is important. And maybe we can pick that one up offline as to how we do that. But I think it's worth saying, Chair, there aren't many of these around. And so I think this is a really good opportunity to say fantastic thank you. And Hannah, just to embarrass Hannah for a second, Hannah, first time she's done this, Hannah, first time you've done something of this level of complexity. And there's nothing like doing a world first to see whether you're any good at it, but clearly you are. So can we just say a big thank you to you, because you've done a remarkable amount of work in this.
Yeah,
And Hannah wants to come back to CPFT.
I know we'd love to have you back. So I think we're being asked to approve the clinical strategy, and I will take nods as agreement. We welcome it, we want to launch it out there, but most of all, we want it to make a difference to how we work and what we're doing. And never forget, this is about serving real people and real places better. And Cambridgeshire and Peterborough are wonderful places for very many who live here, but we have some of the most extreme inequalities in the UK, and that is something that needs to be addressed. They've been stubborn, they have been stuck, but that's real people on the other end of that stubbornness and things stuck. So let's hope this represents a first step, and we'll need partners to engage with us to actually get some movement, which is much needed. All right, can we move on with the agenda then in that case? And Steve, I'm going to you on the high performing organisation programme update, where I think you're talking about transition phase now for this.
I am, Chair, thank you. So the front page of the report talks about the fact that back in December of the previous year, we implemented the high performing organisation programme, which was a collection of best practice and benchmarks with a real sense of holding the mirror up to ourselves as an organisation as to where we fared. That was then followed through with the CQC well-led inspection. That was subsequently followed through by other inspections by agencies that were working with us, for us and around us, supported by RSM, our auditors, who concluded their own internal review and accumulated in an action plan that has been delivered. So page 1 of the report talks about the things that have been implemented since that programme, which I'm really pleased to say has got traction. And the next bit is really just to say to colleagues, the world changed since we started this piece of work. The architecture of the NHS modified itself quite quickly. There is new and different regulatory overview and scrutiny that's been applied, and in some areas, formats, templates, and requirements that are not yet out. For instance, I heard this week that there will be a new nursing and quality performance set of standards that will be implemented, including quarterly performance reviews with providers. And I know Rachel is close to, but these all add to our own overview, scrutiny, and internal machinations of how we provide that evidence. So this piece of work, this paper is talking and asking the board to accept a transition period to move this into our new portfolio architecture that we have, principally delivered around our Foundation Trust reapplication process, our CQC well-led plans, and our regional provider competency, which includes our national oversight framework piece of work. All of the work that you've agreed up until this point will be included in that, and we will route those through the appropriate board committees and bring it back here when we are right to do so. I think as it's safe to say at the moment, looking at my exec colleagues, the guidance around all of these is still very fluid. So I don't want to put anything down yet, because things change quite quickly. And in fact, this week they changed again. But we're on top of it. But I want to make sure that we do it once and in one place, rather than 5 or 6 different places, because that's when things fall through the cracks.
Everybody content with what's outlined here, recognising that the NHS at the moment is awash with newness. We're very blessed. So we have to keep up with that and be able to have sufficient agility to ensure that we're capable of reporting and declaring what we're doing to the right people at the right time. All right, so Holly, we go to you for our emergency planning.
Yeah, thank you. As a category 1 responder organisation, we are required to annually submit our emergency preparedness, resilience and response standards, which is a national framework. And this is just to advise the board that we have made that submission. Our current rating is substantially compliant, so we fully meet 56 out of the 58 relevant standards. We're partially compliant with the remaining 2 standards, which is unchanged from the previous year. The 2 partially compliant standards relate to business impact assessments and also our decision logging process. We have pieces of work around both those areas and expect to be fully compliant with both of those by the end of January. Whilst it is a self-assessment, it was peer-reviewed and supported by the ICB, and it's also been through the Health and Safety Committee and then through to Business and Performance. So the board was asked to note the compliance status and the submitted core standards declaration and the work plan aimed at achieving full compliance.
First of all, congratulations to all involved. However, we want to get the last 2 signed off, so if we can be kept updated of those have been done. Decision logging in particular is incredibly important to be completely compliant on, so that would be great. I'm delighted to say there haven't been any uses of the trust seal, so nothing. I've read it. Not okay. Sorry, Martin tells me that. I've read it as nil. Oh, right. I do apologise. We have used it once on documents related to PFI deed of variation relating to residual of the 20 bed ward, which is not actually with us, but because we're party to a PFI contract with NWAFT, we had to make a deed of variation to our arrangement. So my apologies. That seems like a long while ago now, but excellent that that's been noted. Right then, so we're now into 2 things that need approval from the board. Stephen, both with you.
Thank you very much, Chair. Yes, so first of all is the Green Plan. I won't go through it in too much detail. You've obviously had an opportunity to read it, but clearly there are clear commitments in here for NHS organisations. What you've also got in here is an update in the context of senior involvement. So what we put in place is a new sort of Green Plan delivery board with exec leads, and we are due to meet, I think it's next week, for our first sort of critical board. I think it's really important to get the energy and the enthusiasm behind delivery of the Green Plan. And then just to say this has gone out across the organisation for review and input, and also through the trust leadership team. It's then subsequently come to BNP, where it's being reviewed and signed off, and we're seeking approval today.
Any questions at all on this, Steve?
Apart from the apologies of printing it off, which very conscious of the irony. Oh, good. The chair's printed it as well. For my permanent record, Mr. Lagood. No, it's black and white. I think it would be remiss of 2 things Jess said. This is an excellent piece of work. It's been led out and coordinated with a significant number of the workforce. So a big thank you to our estates colleagues and particularly Alison for leading out on this. The second thing is, when we went through our CQC well-led reports, this area was seen as substantially compliant. So I think it's really good to say that we're receiving a report that we think is really good, but also our CQC and external regulators believe the same. So it's just worth noting that this was an area where they praised us, in fact, in terms of the level of compliance.
Sorry, Mike, Karen.
So thank you. It was really a question of scope, and to be a green trust, it requires I think, conversations with other public sector organisations, so transport, for instance? And do we have the mechanisms to have those conversations? I suppose I got to declare an interest. I was the sustainable NEBS lead at Abbey Rocks when I was there, and I used to talk to Richard, who was there, on this, and for where so housing, transport, waste, all of these things require us to interdigitate with our partners, and presumably that's on the agenda.
It's on the agenda, and so there have been and there are forums. I think it's fair to say with changes in the NHS architecture in particular, there needs to be a bit of a sort of a re-evaluation where you have some of those partnership discussions, etc. But yes, there are forums, we can do that.
It goes beyond the NHS.
Yeah, I mean, it goes way beyond the NHS. I'm thinking local authority, I'm thinking, but in particular, there've been so many changes in the NHS. There are, for example, if you start talking about electrical car points, we're having conversations with different organisations whether we can sort of track in and use those. Some of that's become slightly more complex with the architectural changes that we've seen.
That's sort of a yes, but
there's more work to do.
Yeah.
Karen.
I think it might be too soon to answer, but just looking at the clinical strategy, the health equity strategy, and even the green plan, have we got any sense of how much this will cost us to deliver some of these aspirational things? Now, that is excellent work and we need to do it, but have we got a sense of what any of it might cost us?
So if we just go back to the conversation that Steve started to unpack, but I'm cognizant of time around the planning 3-year integrated plan, that's where we'll draw elements of this into sort of that broader point of deliverability, priorities, what's the workforce, what's the investment in capital, what's the workforce, what's the opportunities that are going around putting electrical points in, for example, for cars. All of that then moves into that world, and then we'll obviously be bringing that up to a board. I mean, obviously, as Kathy said, there's priorities for next year, but there's priorities for subsequent years as well. So again, in our 3-year integrated plan, we've got an opportunity to sort of build that in and make that in going forward.
So that driving prioritisation, I am really hopeful that in particular our health equity strategy might enable other partner organisations to also think about their priorities, because it's brilliant data presented in a fantastic way. And if it could help all of us who are charged with best serving our population to do better, I think that would be a great outcome. Just in terms of the green plan in particular, I know talking to staff, how many of us care so much about this and the environment that we work in and how to improve it. So the more we can make this an engaging, involving, empowering piece of work, we will be for it, I would say. Stephen, seamlessly, the Fulbourn Greenway.
Thank you very much. So this is a paper that has already been to BMP. I'll take it as read. We are looking at approval from the board to sell a very small but long strip of land right at the back of the hospital. It's for £1,000. We have brought the paper actually back twice to BMP because we've made some changes. And one of those really key changes is that it is a sale to Cambridgeshire County Council, or Greater Cambridgeshire Partnership, should I say. However, there is a covenant in there that actually, if they were to use it for anything other than that greenway, we would have then the option to actually buy the land back for the actual £1,000, basically. So it dealt with some of the concern around sort of sale of land and that broader impact on the Fulbourn hospital side. And we're asking the board to sign it off today.
So I would suggest this is us acting as a good anchor institution as part of our community. That would be where I come from, but Steve.
I totally agree. BNP were happy to support this, and linking it back to the previous item, the Greenway running alongside the site is a very positive thing in terms of supporting cycling and pedestrian links to visitors, employees and so forth. So yeah, BNP are happy to.
Okay, I'm looking around the room. Everybody content? Steve?
Very content, Chair, thank you. I think the point that Stephen's just made in terms of the covenant, that doesn't land in the paper, so it would be good for the minutes to make sure that that's included.
All right, so Stephen, we have touched on this already today, but a good item on which to end the actions to tackle racism, including anti-Semitism.
Thank you very much, Chair. So I think actually we welcomed the letter from NHSE in the context of what it was suggesting, what it was saying. We've actually done a review against the letter, and in particular looked at our sort of training and our training compliance, recognising there is still some national work. We've had I think, really helpful and healthy debate around this actually at the People and Culture Committee, which we referenced earlier on. But we also recognise there is further work to do as well around this. So we recognise this all around sort of the culture. We've obviously got the delivery of the ED&I strategy as well. And also we know that there's additional information coming down around sort of uniform, etc., and also further training requirements. And we're asking the board to note this today.
Well, it's another document to note. It is incredibly important and goes beyond the document that we do what we're being asked, which is to be serious about being anti-racist, including anti-Semitism in that, and for it to be noticed by our staff that what we do is meaningful. So I would just ask if we can keep coming back to this through the subcommittees, and the main board does feel incredibly important to me. Sure, I'm looking around. Mike?
Yes, and one of the questions that came up at P&C, I think, was, do we know what it's like to work in this organisation if you are Jewish, Christian, Muslim, or anything else? And that requires dialogue with our staff and to hear what they have to say, rather than simply having this. And that's not easy to do. My suggestion was Scarlett Brown is one way of getting a window on this, but yeah. Anyway, I reiterate the point that was made at P&C, which I think is important.
It's often a protected characteristic which is least talked about, which is that of faith, and we should not be shy of that. And you know, protected characteristics are often people have more than one. We did some training the other day. We were told that we all had at least 2 or possibly 3. So just say we need to find a way of making sure that we work on the basis of understanding how it feels, as Mike says, and do all we can to improve experience and to celebrate the experience of faith as experienced by our staff. But Stephen, last word.
So I think that was a great suggestion. So we are looking at that. We're also looking at whether we can, we've got the People Pulse survey, so whether we can put additional questions and additional information in there so we can use that. Then I'm actually meeting the chaplain this afternoon to have a conversation as well around sort of how do we sort of embed more of this in that faith being one of those particular issues.
All right, with my apologies, we have now gone 2 minutes over our allotted time. I'm going to have to say thank you so much to everybody who's joined us today, our governors, members of the public, colleagues who are currently staff, have been staff or will be staff, some of whom I know have all joined us today. So it's great to have you with us. Everybody here in the room, enormous thank you to you. To Chris and Pri, who'll be joining another meeting essentially straight away. If you could do so, that'd be great. But please have a good week and stay healthy with the benefit of vaccinations, which is very much. Take care now. Bye.
Bye.